Good day, everyone. My name is Manjula Narasimhan, and I will facilitate today's webinar as part of the series led by the Interagency Working Group on linkages between sexual and reproductive health and rights and HIV linkages. This Interagency Working Group was established in 2004 and is co-convened by UNFPA and WHO. And my colleague from UNFPA, Tim Sladden, chaired the previous webinar of this group last year. And for next slide, please. A few points. This webinar will be recorded and will be shared with the attendees. And if you have any questions at any time, hello?
Yeah, Manjula, go ahead.
Go ahead. If you have any questions at any time, you can feel free to type any of them on the question box on the control panel on the right-hand side of your screen. And at the end of the presentations, I'll direct the questions to the panelists. But if we do not have time during the webinar to answer all your questions, we will get back to you after the call. Also to note that there are additional resources on the handout section in your control panel. And do feel free to download them and share them. You will see that there are 5 handouts included. Next slide, please. So today there will be 3 presenters for this session. And really just to go back, the purpose of these webinar series is to share key topics on SRHR and HIV linkages and really highlight the important works of the members of this working group on the Interagency Working Group on SRHR and HIV. And we know that the vertical policies, the vertical programs, and the funding and institutions, they continue to pose challenges in the provision of comprehensive, people-centered approaches to health. And the examples that we will hear from today and throughout this webinar series really offer opportunities to meet the needs and the rights of even the more vulnerable populations. And today we'll focus on adolescents living with HIV, and we will hear from 3 speakers on some of the very exciting work that's happening now, but also tangible results that can go a long way in improving lives. I have the pleasure now to introduce our first panelist, Addison, who is Senior Technical Advisor for the Implementing Best Practices Consortium, known as the IBP Consortium. And Addis, over to you.
Thank you, Manjula. Good morning and good afternoon to everyone. Today, I have the pleasure to share with you some key facts about IBP, who we are, what we do, and the role that our partnership plays in disseminating global tools, including those addressing the linkages between reproductive health, HIV, and young people. The Implementing Best Practices initiative brings together implementers, policymakers, donors, and researchers working primarily on reproductive health and family planning. In 1999, WHO, USAID, and UNFPA, along with 9 implementing partners, decided to create a space for knowledge sharing and collaboration in family planning. We started with these very strong and committed organizations, and through the years, the partnership has grown to more than 60 organizations that are based all over the world. IBP collectively benefits from a diverse implementation experience and an extensive network of partners managing, implementing, and researching best practices. We are also a member of this Interagency Working Group on Sexual Reproductive Health, Rights, and HIV linkages, and actively work with the working group to support collaboration with the global community. Housed at the Department of Reproductive Health and Research at WHO, IBP offers a neutral platform for collaboration and a unique opportunity to link the normative work of the agency with organizations implementing on the ground. IBP has a diverse membership that ranges from global implementing partners to regional organizations on to national and local NGOs working in family planning, HIV, and other health topics. We believe that the strength of our partnership derives from the diverse experience of our members and their ability to document what works, so we avoid duplication and use available resources more strategically. This infographic captures our major activities last year, and they're organized around the three strategic goals that I'll go into more detail on the next slide. So these are our three strategic goals. First of all, we work to increase access to WHO tools and other evidence-based guidelines. These include the tools that WHO produces. Most of them, or the ones that we support, are here on the screen, as well as the high impact practices in family planning and the scale-up tools. IBP supports implementation of what works in family planning by undertaking documentation of implementation experiences, convening technical groups on various topics, and partnering with our members to organize conferences, technical meetings, and consultations. Our third objective focuses on the creation of a collaborative space for our partner organizations, including face-to-face and virtual exchange channels. For example, our virtual knowledge gateway is a community of practice of more than 15,000 members working in FP, HIV, and other health topics. We lead an implementers track at the International Conference on Family Planning, convene technical meetings, and work with regional organizations such as WAHO to organize the West Africa Best Practices Forum. Through a series of webinars, IBP creates opportunities to learn what other partners are doing and how they're integrating global guidelines and evidence into their programs. We value this approach because we have an opportunity to reach a large number of partners in diverse geographies and engage them in our work. As a strategy for rapid dissemination, we started organizing webinars on implementation of high-impact practices, bringing together global and national voices. This approach has been very successful, and we have used a similar model to disseminate other tools and guidelines. To date, we have reached over 5,000 professionals around the world. Between 2017 and 2018, IBP supported the dissemination of the Consolidated Guideline on Sexual and Reproductive Health and Rights of Women Living with HIV, convening region-specific webinars to disseminate the guideline. We held webinars introducing the tool, but also taking into account the particular context of all the regions, the WHO regions in the world, including Southeast Asia and the Pacific, Latin America and the Caribbean, Africa, and the Eastern Mediterranean regions. I also like to mention that we did these webinars in multiple languages. At a national level, IBP supported our colleagues to convene a series of 4 webinars in Canada, bringing together global and national partners to disseminate and adapt the guideline to the specific Canadian context. IBP participates and supports the development, dissemination, and documentation of high-impact practices to address the reproductive health needs of adolescents and young people. There are a number of key tools available, and these include the Adolescent-Friendly Contraceptive Services HIP, the Strategic Planning Guide to Improve Sexual and Reproductive Health of Young People, as well as other evidence-based practices such as educating girls, digital health, and community group engagement. We supported the documentation of adolescent-friendly contraceptive services implementation in India and Colombia, and this will be published in the near future. IBP engages young people to build capacity around reproductive health in our technical meeting and conferences. And for example, the India adolescent-friendly contraceptive services documentation was led by a young professional. I would like to close with a recent quote from one of our members based on the field. And while you see that on the screen, I'll also know that while we recognize that there are many challenges, we know that a key strategy to address those challenges is to partner for knowledge sharing to reduce duplication. IBP is committed to this principle, and we rely on our members to help us advance this work. On behalf of my colleagues at the IBP Secretariat and our members, I want to thank you for your participation and for your attention today. Manjula, over to you.
That was a really great overview of the IBP work, and we're going to move on now to our two presenters who will be taking turns giving this next presentation. So Cecilia Kihara and Maximina Joconia, who goes by the name of Maxie, and they're members of the Ready Plus program. And this program, led by Frontline AIDS, which was formerly known as the International AIDS Alliance, is working to give tangible changes at the service facility levels and bring out more integrated service delivery to meet both the SRH and the HIV needs of adolescents and young people living with HIV in Southern Africa. So Cecilia and Maxie, over to you.
Great, thank you, Manjula. Hello, everyone. So as Manjula said, Maxi and I will be doing a kind of double act this afternoon, this morning, wherever you are. And we're going to be presenting lessons we've learned so far from implementing Ready Plus, which is an SRH HIV program funded by the Embassy of the Netherlands in Mozambique. And it's implemented by a really innovative and multidisciplinary consortium of youth partners, SRHR partners, HIV, and also communication partners. We've left their logos online so you can see who's taking part in this program. I wanted to just mention briefly that Frontline AIDS is, as Manjula highlighted, the new name of the International HIV/AIDS Alliance. We actually rebranded about a month ago, and it's because we strongly believe that this, our new brand, will really help us to maintain our focus on AIDS within the broader global health dialogue, which includes championing AIDS in the context of the SDGs and the emerging discussions around UHC. As we all know, many of the people we work with and for, and especially adolescents living with HIV, continue to be left behind, and especially those that are marginalized experience discrimination on a daily basis. So we are very, very strongly on the belief that this new brand and strategy will refocus our efforts to end AIDS. So really excited to share this with you, and thanks for joining us. I'll just hand over to Maxi for the next slide to set the scene.
Maxie, are you online? Cecilia, it looks like Maxie may not be there, so maybe you should continue.
Okay, she's probably trying to unmute. So I'll just set the scene for us. We'd like to begin by sharing with you a video that will show you the life of Nsiki. Nsiki is a community adolescent treatment supporter from Eswatini, one of the countries where we are implementing Ready Plus. And in this video, you will see her working with her peers, both in the community and in the facility. And this is one of the ways that we're trying to establish the strong link between these two parties. We'll talk a bit more about the CATS role a bit later, but for now, let's see the video. Ados?
When I first find out that I'm HIV positive, I felt lonely and angry. I just needed someone to help me, give me advice and counseling. On how am I going to take my treatment at the right time, right way, consistently. I'm Ziggy, a lady of 22 years. Kuba ikhet ngicabanga ukuthi ku contribute much in my life.
The challenges that adults have and the challenges that young people have are completely different. there are young people living with HIV who are offering services to their fellow peers who are HIV positive.
The cats are very important. There are those who are scared in coming to the facility. So then the cat, when they reach them or they visit them in their respective homestead, they are making work easier for the nurses in the facility and easier in the outside world.
If someone of my age comes to me and helps me to think, to refocus, I'll just see there's light, there's hope.
Kuloko ngiyengikhanze ngathi kulula lokuthi lomunye adisclose kulomunye longangaye cause mina ngimdzala utawuhluleka lo mfana lokungibhobokela kwekuthi yena uphila neligciwane.
If they are HIV positive and batolahla ihope ukuthi no, they can't do anything just because it's HIV. So my role is to empower and encourage him or her that even if you are HIV positive, you can still fulfill that dream and hit that goal.
Because nyalo sengitiva nami ngumuntu because the more ngikhuluma nemuntu lengilingana naye the more nami ngikhona nje kubika tonke inkinga tami kuye and kuba ngcono ukuthi ngisithe nami umuntu engilingana naye and futhi nami ngiyakuthanda.
Some said, Auntie, I've realized that HIV is not in my brains, but is in the blood, and the sky is the limit.
Helping people like Sipho makes me feel proud of myself, even proud of my job. And my dream is to become a full-time counselor, especially to young people and adolescents living with HIV and AIDS.
Great, thank you, Ados. So with that scene set, we want to jump right into discussing the few lessons we've picked up in Ready Plus. So important to mention that we're 2 years into the 4-year program. So what's Ready anyway? Ready stands for Resilient and Empowered Adolescents and Young People. And at Frontline AIDS, Ready has a set of interventions or projects, we call them, that sit under this banner. One of them is Ready Plus that we're going to be focusing in today. And it's purely looking at integrating sexual and reproductive health and HIV, as well as psychosocial support at one stop for adolescents and young people living with HIV. Next slide. So where did Ready Plus come from? Many of you might remember a program that we were implementing a few years back called Link Up. So Link Up was one of our first forays into integration and linking up SRHR and HIV. It was implemented in 5 countries, 3 of them in Africa. So when we finalized it at the end, actually in the middle of 2016, we brought together focus group discussions of young people at Durban 2016. And one of the questions we asked them was, what is the 1 or 2 things that you really feel was left out of implementing Link Up that you would want to see in a new iteration? And overwhelmingly, the main issue that kept coming up is around psychosocial support, looking at mental health, and looking at the softer issues really that go along with a young person that has been born with the virus and is living with the virus and just trying to forge their way in life. So Ready Plus was really designed as a multi-layered intervention program. So looking at SRHR, we're looking at mental health, we're looking at care and treatment, but there are also issues around social protection that we're looking at. We're looking at reaching 30,000 young people living with HIV in 4 countries in the SADC region. So in Eswatini, in Mozambique, in Zimbabwe, and in Tanzania. Next slide, Ados. And over to Maxie.
All right, thank you, everyone. Just like what Cecilia said, my name is Maximina Jokonya. I'm coming from Zimbabwe, working with an organization that is called Africa Drandiri. So this case model that we're talking about today, which we see as a youth leadership across the project, it started back in 2004. whereby we're saying young people, they came together with this idea that yes, ARVs work for us, but sometimes we need support beyond just getting ARVs. So they created a support group which they meet and share their experiences. From there, the CATS model was actually built. So the community adolescent treatment supporters are young people between the ages of 18 to 23 who are living with HIV, who can be selected by the implementing partners and also the Ministry of Health, depending on the country-specific context. So I'm trying to expand on the issues of CATS and where it came from. Africa is the one that is championing this model, and also it is the one that is now scaling up the CATS model to the rest of the country and also to the rest of the region, which way we are now seeing the 4 countries being involved and also being championed under the Ready Plus project. So we are saying Ministry of Health can be involved, implementing partners can also take part in supporting and mentoring these kids to be able to support other peers on the ground. Next slide, Addison. So what do community adolescent treatment supporters do? Just like I mentioned, they are young people from the ages of 18 to 23 years old living with HIV. So we say it's our core interventions, it's our core programming of our programs, be it in Africa, be it together with Ready Plus. We put the young people at the forefront. They are the ones who come up with the projects. They're the ones that comes up with intervention that they want to see in their own lives. So the kids are the peers that continue to provide these differentiated care services. We are saying each and every adolescent has got a unique needs that we must meet. Every adolescent is not the same. So the kids, they go to the facility, they go to the community, providing these differentiated care services. So kids in the community, what do? They create safe spaces for adolescents and young people with HIV. These safe spaces can also include support groups, teen clubs, the camps and after school activities. This is where they share their experiences and also make sure that they help each other in terms of the challenges that the adolescents are facing, be it SRH issues, be it the issues of disclosure. How can I tell my boyfriend when is the right time to tell that my boyfriend or my girlfriend that I'm HIV positive? These are some of the questions that are addressed and discussed during these clubs as well. They do SRH counseling and information giving, whereby we are saying adolescent young people, they do deserve these services. They have a choice to actually go and access these services at different, be it in the community and at the facility. They also do home visits. Home visits, that's when they also do counseling on these issues of adherence using tools like the soldier game and other tools that helps their peers to actually understand more on the issues of adherence, on the issues of disclosure, on the issues of sexual and reproductive health. They do data collection and entry. Whatever they do, they record, because we say we want to track the program and to see if it's effective and also be expanded into other countries as well. They also do condom and lube distribution as well in relation to the sexual, reproductive and health. They also refer their peers to the health facility, so that at the end of the day, if their peers are not feeling well, they're able to identify and also refer this to the nearest facility. They do referrals for social protection and other services in the community. For social protection, we're looking at the issues of violence, issues of neglect for children and adolescents with HIV, issues of stigma and discrimination. So we know that adolescents and young people, they are more vulnerable to these social protection issues, and also social welfare. Do they have enough clothes? Do they have enough nutrition? Do they need anything in terms of assistance with medical assistance, with education? This is what they do in the community, and they refer to relevant stakeholders and partners. At the facility, they continue, they work at the reception, welcoming the adolescents, because we are saying the services for adolescents should be youth friendly. So when an adolescent walks into the facility, they see a kid who's very friendly, with the same age as theirs. They become very free at the facility. They become very open, and they tend to discuss more about their issues. They do adherence counseling, they do SRH counseling, they do also condom and lube distribution, just like what I mentioned before. They also facilitate support groups and also the clubs that I've talked about. They also do health talks and treatment literacy. They also provide EC materials on different topics. Let's say, for example, we don't only talk about the issues of HIV, because sometimes adolescents, they say, we want to go beyond HIV. We are adolescents who are growing up. How can we make sure that our life is encompassed with full information that enables us to live happy, healthy, fulfilled lives? So they can do on hygiene, they can do on their dreams, what they want to become in life. They also do data collection and at facility level. They also refer to community implementing partners and kids for PSCs as well. Next slide, Ados.
Great, thank you, Maxi. So what you're looking at on that slide are the 4 outcomes that we're working towards under Ready Plus. So the first outcome is based on just working with for adolescents to build resilience. Second outcome is really placing ourselves right in the middle of communities, because we know that adolescents and young people don't live in a vacuum. They may be receiving services in facilities, but they do live with a society, within the bigger society. The third outcome is around working with ministries of health, working with government and also community-based facilities to ensure that there's access to services. And the last outcome is really around accountability. So how do we talk to young people to find out what their gaps and their needs and their challenges are? How do we do research around that? How do we extract evidence and package it in a manner that a young person can present at a different policy making level, be it at the district, national, or international stage? So those are the 4 outcomes which we'll dig into one by one together, so we can pull out and kind of try and just show you what we've learned 2 years in. Next slide, and over to Maxi.
Okay, thank you so much, Cecilia. So just like what Cecilia said, the outcome 1 is looking at how can we build the resilient and empower adolescents and young people with HIV, and how can they be better informed and make healthier choices for themselves. So just like what we said, we are looking at peer support, whereby we are looking that through relationships with peer supporters, adolescents and young people, they are so they make sure that the kids, they are there to support this guidance, they are there to support, to give this information and navigate through the service. Let's say example, a child goes to a certain clinic, they are supposed to actually access sexual reproductive health, for example. The kids are there to actually help these adolescents to be able to access these services. So that's the peer support that we are talking about, that that same adolescent is being able to be supported by the kids as well, to access information, be it on adherence and also on sexual and reproductive health as well. On the second point, we are saying we are creating safe spaces for adolescents and young people living with HIV to meet and learn and build that their trust as well, and also by making sure that the information that they receive is up to date, and also they are able to empower them, because we know that if they've got the accurate information, they've got that boldness, they are empowered, and they are resistant to each and everything that may come their way, be it is stigma and discrimination within their communities. They're able to be empowered because they know that HIV is, it's in my blood, it's not in my brain. It's something that is manageable, and I'm able to live a longer life. So this is it's some of the information that they're empowered with. They are also empowered with information like sexual reproductive health, where they can access services, be it family planning if they need it, be it just information on how to inform them better on sexual and reproductive health. On the last point, we are looking at the information and education that is called IEC materials, whereby they can actually go with this material and read more of them, even when they're at home at their own time. So with Ready Plus, we actually managed to develop some of these too, whereby you're looking at the issues of child marriages and when do they decide to have sex, when do they decide to disclose to their partners, how do they decide. I think these are some of the questions that adolescents and young people with HIV have, and these materials are able to actually answer some of these. I am sure we also have got the soldier game, we've got the red ribbons and roses as well as soldier games, and also the tools that are mentioned here. So I think in a nutshell, at the end of the day, we are saying if we give the information, if we provide peer support, and if we provide the safe spaces, adolescents and young people are able to live healthy, happy lives at the end of the day. Next slide.
Great. So around outcome 2, what are we trying to achieve? As Maxi shared, when we're working with adolescents to develop IC materials, most of them tend to be on really sensitive topics. So you saw on the picture there around learning about STIs, learning about condoms, when to start having sex. When we hand out these IC materials, of course, the young people will take them home, right? So in the last few years, what we've learned is we can never underestimate the role of parents, the role of caretakers in engaging their young people. In most instances, under Ready Plus, we've learned that it's really the language that parents and caregivers lack in terms of engaging on sensitive topics such as sexuality. But even before you get to that point, there's all these pieces around disclosure. When do I disclose status to my child? Sometimes we hear cases where young people are taking medicine, but they're not sure what they're taking the medicine for. So we found that within Ready Plus, it's been really critical for us to work with parents, with teachers, with caregivers, basically any person that an adolescent would be relying for information, to ensure that they have the confidence, that they have the language, that they have the materials to be able to speak to the reality of a young person living with HIV in relation to SRHR, so that you don't end up handing out an IC material to a young person, or maybe they've gone to the clinic, they've seen a nurse and have started on a contraceptive, and then they have to go home and hide it, or it's left in their backpack and it's found at a later point, and then there's a lot of misunderstanding within the home. So within Ready Plus and really all of our Ready projects, we found that it's been really critical to ensure that we're working alongside with parents. The other piece is really linked to what Maxi mentioned earlier, that cats do work in homes. So when cats go into the home, first of all, we've already established that trust with the parent, so they know that the cat is coming in with information around health. And sometimes they will sit and just walk along the discussion with their young person. Most times they will just let the cat just, talk to their client, and they're free to just engage in other aspects of discussions, be it in relationship or what have you. But we've also found that to be a really good entry point to just assess the home and see if there are other social protection issues that we need to raise for case management at a later stage. So the biggest lesson here is walk alongside the community, don't work in a silo. Next slide, please. So the third outcome, as I mentioned earlier, is around working very intentionally with health facilities and also with the Ministry of Health, and ensuring that we're working within the national context. All these 4 countries we're working in, and really all the countries that we engage with in sub-Saharan Africa, already have their own standards and guidelines of how to work with adolescents and young people living with HIV. So under Ready Plus, we've really been fortunate enough to borrow from the CATS model that has been implemented in Zimbabwe for quite a long time. And what we've learned in the 2 years is by consistent and intentional engagement with the ministries of health, they have really accepted and seen the gains that have been made in Zimbabwe. I'll highlight one of the publications that produced results from an operational research piece in rural Zimbabwe on the CATS model, and it showed that 12 months in, every young person that received support from our CATs was retained in care. I will be able to share that later. And my apologies for not including it in the handouts. But based on this piece, we were able to then engage with ministries of health in the other countries and start building up, putting the foundations on the ground for it to be rolled out. The training of the health providers really ensures that they are able to provide SRHR services across the board to this group, and ensuring that it's age differentiated and it's very tailored to the needs of the specific person that they're working with. The other thing that we've really taken on board from one of our partners, which is the Global Network of Young People Living with HIV, is that young people sometimes have lots of feedback to provide to nurses, but they don't know what angle they should use. They don't know how to do it, because this nurse, they have to keep seeing each and every time they come back to the clinic. So you want to keep your relation all nice and lovely, right? But sometimes they want to tell them how they feel about how they're being treated. So the Global Network of Young People Living with HIV worked with their colleagues across the 4 countries, and they developed what you see on your screen, which is a toolkit called Ready to Care. And Ready to Care is really a tool that young people within Ready Plus are using to monitor and accredit services. It's written in really simple language and just tells the service providers how young people would like to be treated, and it's included as part of your handouts. Next slide, Ados. So we've just tried to put for you just a few basic highlights of the services that we ensure that we are providing across the board. As Maxi said earlier, when the CATs are in the facilities, their supervisors, their mentors, and their coaches are really the nurses themselves. And they work with them to deal with the trickier issues that the adolescents might not have grappled, that the CATs might not have grappled with at that point. So looking at providing support around ART provision, the viral load monitoring piece. They also work together to do screening of TB, opportunistic infections, and in most cases, and in some cases actually I should say, we've also received clients that really want to have a broader access to broader package of SRH services specific to pap smears, breast exams, and all that bit. So in those cases, you have the nurses that are working side by side with the CATs to make sure that the service is provided. Where it's not available in the 24 facilities that we work with, we have a referral mechanism that we've been using across the board. And as many of you would know, there's issues around referrals, but we're learning lessons as we go along. The biggest piece of, I think, or the biggest lesson I would say from this piece of work is we found that there has to be a very live and direct and strong relationship between the community implementing partners that are working with the community CATs and the facility itself. So brokering that relationship and ensuring that the power balance is about right to make sure that these channels of communication remain open and that you're able to track somebody's pathway through that referral mechanism has been really important. Next slide, Ados.
Okay, thank you, Cecilia. So I'm going to talk about what we hope to achieve with this Red Plus project, the outcome 4, which is talking about the greater accountability of decision makers and policy makers and how they can hold this, how we can hold them accountable to provision of SRH needs for adolescents and young people living with HIV. So in this outcome, we are really looking at how can we empower adolescents and young people to be able to identify their sexual and reproductive health needs and be able to advocate for them. So they start by communicating the evidence. They acquire the evidence, what is missing, what is being provided, and what do they need in order for them to fulfill their needs in terms of sexual and reproductive health. So what they do is they communicate at different levels, be it at the community, be it the regional, be it at national, be it global level. They also assist some things like the risk with regard to sexual and reproductive health. They also identify the barriers that adolescents and young people are facing in terms of accessing, in terms of affordability, in terms of how these sexual and reproductive health are speaking to the issues of adolescents and young people. Sometimes the services, they might be there, but sometimes they are not tailor-made for adolescents as well. I remember at the one support group, adolescents were saying the condoms, yes, they are there, but they are not flavored. We want condoms that are flavored so that we'll be able to enjoy them. So these are some of the things that the advocacy part is really looking at. And also we are holding the policymakers, the decision makers for accountability. Yes, we are saying the frameworks are there. This is what the young people are saying. The frameworks are there, but at the end of the day, they are just in paper. What about delivering them at community level? So these are some of the issues that they are talking about in terms of how can we make sure that these services are reaching out to us. So together with young people, they've developed what you call Ready to Advocate. It's a mentorship booklet whereby they're looking at the stages, how they can acquire they can do research to acquire data on the gaps that are there in terms of sexual and reproductive health provision, and how they can be able to advocate in a way that is able to achieve results. So you can see the tool that is being attached there, whereby it helps the adolescents and young people to be able to advocate for their issues. For example, we have under Ready to Lead, which is part of the Ready Plus project. We have managed to train and mentor young women living with HIV to be able to advocate for sexual reproductive health. Let's say, for example, STI screening and diagnosis. And this wasn't in their clinic, and they've managed to advocate for these services to be able to be present. Some of these young women, they are now empowered enough to be able to advocate at the global level. I remember last week I was with two of them at UN for Women, that is the Commission Status for Women that is currently happening in New York, whereby they were really talking about the issues of sexual and reproductive health, looking at the issues of choice, to say, yes, we might say the family planning is there, but are they talking to me? Sometimes if I go on the ground, I results, and also in leading to the universal health coverage that we are going to be looking at in September. These adolescents and young people, they're also voicing their issues, their priorities to be also addressed during this universal health coverage meeting as well. So this is what we are looking for under Ready Plus. We are mentoring them, and the kids are also on the forefront of mentoring other young people and adolescents to be able to air their views and their voices as well at the end of the day. Next slide.
So what does it all add up to then? We have learned over 2 years that adolescents and young people in their diversity really do have a stake in designing, in implementing, in monitoring, and in advocating for their own SRHR needs. We've heard from our nurses in the clinics, and you saw the nurse from Isatrini, Iyanda, talking about the role of the cats. They do see themselves really as a key component of the success of the work so far. They understand themselves as agents of change. And we've learned that we need to look broader than HIV. We've learned that SRHR is a key component of healthy living and well-being. We've learned that the link between communities, especially through the implementing partners and the health facilities, is really, really critical. What has really helped us is also that we've signed memorandum of understanding between facilities and implementing partners to be able to make those channels a bit more flatline, making sure that our referrals are always on point. We've learned that young people, when provided with a space, can really step up and make sure that they are receiving the SRHR and HIV HIV services that are tailored to their own particular status in life. So with that, we hope that you will join us, end it, and I will hand back over to Manjula. Thank you.
Thank you both so much. And I think that we can thank all three panelists for really thought-provoking presentations here. And just given the numbers of people who are on this call, it clearly highlights the importance of not just addressing the prevention needs of adolescents and young people, but also the comprehensive health needs of adolescents and young people who are living with HIV. So thank you all very much. I can invite the audience to include your questions in the chat box. So there's a panel on the right-hand side. So you can click on it and type in your question, and we will ask one of the panelists to respond. While we're waiting for the questions to come, maybe I have a question I can start off for you, Maxie. On how do you ensure effective referrals, within and between facilities for the SRHR services that are not provided on site? So I'm assuming not all the facilities have a one-stop shop. So how do you ensure those referrals?
Okay, thank you so much, Manjula. So just like what I mentioned during the presentation, that the kids are at the forefront of, identifying the needs that adolescents and young people do have, and be able to refer to certain whether partners or whether facilities that do provide these services. So what they do is the kids, they initiate the referrals and they refer to a certain clinic. So if the services that they are inquiring is not at the clinic X, what they do is they work together with the case to be able to also further refer to X, Y, or at district level or at provincial level. So what happens, let's say for example in rural areas, yes, the kids are there and they initiate these referrals, but sometimes that issue of bus fare to be able to access these services. So that's when the district or the implementing partners are able to actually provide with a small fee of bus fare, or look on refer to other partners that are offering bus fare for adolescents and young people to access services. So the case, they make sure that they track this referral up to the end whereby an adolescent has received the services. And also Cecilia also mentioned that it's important to work together hand in glove with other partners that are providing services, with the clinics that are providing services, to have a good relationship, so that at the end of the day we are able to provide the services to the adolescents and young people living with HIV. So the case, they do meet up, they have meetings with implementing partners, they have meetings with clinics at a nursing level, whereby they are also included in those meetings, so that they talk about this issue for effective referral and offering of services on the ground. So that's what I can say. I don't know if Cecilia have got more to add on that one.
Oh, no, it's perfect. Nothing to add.
So there's several questions that have come in now. We may not have time for everything, but I'm just going to try and ask at least a few. So one of the questions here that's been asked is, what are the tools for changing the perception of young people living with HIV? I guess in relation to the stigma. And then there's another question here. So I'm just going to ask maybe two or three, and then I let you answer. Are the cats reimbursed for their time, for their travel, and how are they incentivized? And what are the mechanisms for monitoring the impact of the different cats' activity? So maybe I can ask Maxie, Cecilia to take those two questions, and we'll move on to the next.
Great. Maxi, do you want to take the questions around tools for changing perceptions, and then I'll take the second one?
I didn't quite get the question. I'm not hearing Manjula very well.
Right, yeah. So she asked around the tools that we use for changing perceptions of adolescents and young people living with HIV.
Oh, okay. Thank you very much. So about the tools that are being used especially to change the perception of adolescents and young people living with HIV, they actually come from the young people themselves living with HIV. So what we do, just like what I mentioned before, that our program is peer-led. They are the ones who are on the forefront of delivering what they want to see. So at the end of the day, the kids are able to also consult these adolescents and young people living with HIV on how best we can save them, on how what tools they feel that it can enhance, be it sexual reproductive health, be it the issues of disclosure. So like for example, we have seen the tools that are already in the presentation, like ready to care, like ready on the advocacy and other tools. These were developed by young people themselves to say we need to make sure that these actually work for us and other young people who are out there who might not have more information. So these tools, they actually be able to change the perception of adolescents and young people, because the tools, they've got the real life experiences of adolescents and young people living with HIV. They are the ones, sometimes they're those who are able and willing to share their stories on how they, where they were and what happened to them, what services do they receive, and what is happening to them now. So these are kind of tools that we develop. At the end of the day, they're able to change even the perception of adolescents living with HIV. Let's say, for example, for someone who's in denial of his or her own status, and they need that encouragement to say there's life after HIV, they can actually read these stories that are in the tools. They can actually read encouragement from others who have walked the walk, and also the case, they are the living experiences, because they are the role models of adolescents and young people living with HIV. So at the end of the day, these tools, they're able to change the perception of adolescents and young people living with HIV.
Great, thank you, Maxi. I'll take the next question around whether we reimburse CATs and what kind of incentives we have within Ready Plus. And the answer is a resounding yes. We do reimburse CATs. They've got a stipend, a monthly stipend that they all receive for the work that they're doing, because it is actual work. In Zimbabwe, we have seen that the Ministry of Health has been very enabling and has been working side by side with Africaid, because they're actually the ones that supervise and monitor the young people when they're doing the work within the facilities. In the other 3 countries, because we are 2 years in, we've made some progress. And in the perfect Cecilia world, I would say CATs really are part of the community health extension workforce that we have across the region. So yes, we do reimburse them. We also have a streamline of work that we call caring for CATs, and this is sessions where the CATs sit with the partners at the implementing partner level to just talk through different challenges or opportunities that they foresee as they're graduating out as CATs. As Maxi mentioned, they are aged between 18 and 23, which means at some point, in most times, if they finished high school, they want to go on to be employed in other sectors. You saw in the video that Nsiki actually wants to be a counselor, but there's some that want to do other kinds of work. So we're thinking through within Ready Plus how to link this work with the broader sector. So looking at vocational skills training for CATs that are graduating out of the program. But within the program, what we've made sure to do is that we run different trainings hand by hand with CATs. So for example, last year we did a set of SRHR 101 trainings for implementing partners and health providers, and CATs would run this with us. They're part and parcel of designing innovative apps, that one we call the CATs app. So they are the ones that are designing the app with software designers that are working with MNC Sachi, one of our partners within the grant. So there are some skill set that they're picking up along the program. But that's a really good question that we're still grappling with. So happy to hear any feedback. Thank you.
Thank you both very much. And we have very few questions, so very few minutes, not questions. We have lots of questions actually. So I'm just going to ask just 2 more, and if you could just give brief responses to that, Cecilia or Maxi. You know, what are the challenges that Ready Plus has encountered? You know, have there been specific challenges, and what have you done to maybe bridge the gaps, the barriers, for instance, between the service provider and an adolescent, young person who's in need for care. And then one other question is, are there plans for scaling up?
Great. Okay, so I'll take that. There's always challenges. I'm wondering which one to talk through. I think one that I can place into context, because we're looking at really how to establish these links between the communities and facilities, is what I've been stressing all through is power imbalance. So we found that when we started implementing that, CBOs found themselves in a peculiar position where they could not really engage with the technical language that doctors and nurses often engage with. So it would be very difficult to bridge that gap between CATs that are in the communities bringing their peers into the facility, or having a program manager in an implementing partner, a small CBO working with a nurse. So we found that we had to do lots of work around the softer issues to just make sure that that link is there, because we want our referrals to go to plan. The underpinning challenge that came out of that is we found it slightly difficult to access data from the facilities on completed referrals. So we wanted to make sure that that engagement and that power imbalance is flattened out somehow. So just one of the challenges we've encountered within this. The other one is around how service providers engage around contraception, access of contraception for younger age groups. So just talking through their own values, clarifying values. How is it that you provide informed consent, and how do you provide services without making sure that you are balancing between the evolving capacity of the young person and providing adequate care. The last question you asked, Manjula, has just flown out of my head. It was around challenges and
it was around scale up.
Scale up, yeah. So we've scaled up. We're now scaling up to the 3 countries, so Eswatini to Mozambique and to Tanzania, but also looking at East Africa currently, because in East Africa we've been implementing a project called Ready Teens. So that's where we want to layer something else that is particular to the CATS model, because we've seen how acceptable and how effective it's been to bring adolescents and retain them in care. So yes, there are plans in the works.
Thank you all very much. And I realize we have a lot more questions. And what I suggest is perhaps we can send these to the presenters, and we will try and respond to it and send you emails back. And really want to thank all of you for participating in the webinar, for the insightful questions and the valuable feedback that we constantly get through these webinars. And please join me in thanking the panelists and IBP and all our members of the Interagency Working Group on SRHR and HIV linkages who made today's webinar possible. We will be sharing the recording of the webinar with everyone and also posting it online. And the presentations will be emailed to participants. And the topics for future webinars will be also communicated with at least a month's notice, so that you can join for our next webinar. Thank you again all very, very much, and wish you a good rest of your day.